Mm. Ah, म्हणजे हो का? एवढं बसलेलं होतं. अरे खरं.
Good morning, everyone. We shall start in another 10 minutes. Good morning, everyone. We'll be starting our webinar in next 10 minutes. Thank you so much. Good morning, everyone. The speaker for today, Dr. Kaustubh Sansare sir, will be joining us soon. Due to some technical issues, Dr. Kaustubh will be joining us soon in another 10 minutes.
Good morning, everyone. I apologize for the delay. I think Sansare sir has difficulty in joining. Now he is shortly joining us.
Hello.
Yes, sir.
I think I have joined.
Yes, sir. You are seen, sir.
Okay, now I have to share the screen.
Yes, sir. You are seen.
I have to share the screen.
Yes, sir.
So I go to present now, right? I go to present now, right?
Yes, sir. You have share your screen, sir. Present now.
Present now, entire screen.
Yes, sir.
Allow. Okay.
Yes, sir. You are there, sir. You have to just do the screen share. Yeah.
It's seen.
Yes, sir. It's fine, sir. We'll just do the introduction and then
Okay.
we can start,
Okay.
sir.
Okay.
Sorry, sir.
Yeah. In fact, I am sorry.
Yes.
Good morning, everyone. I sincerely apologize for the delay that happened today due to some technical glitches. And sir has finally joined. Respected teachers, senior faculties, friends, and my dear students, it's a great fortune that we have amongst us Dr. Kaustubh Sansare, sir. And I welcome you all from the Department of Oral Medicine Radiology, Shiksha Anusandhan, deemed to be University Bhubaneswar, to the fourth webinar of our mega webinar series. Now, already we are late, so I will not keep you further. Everyone knows that the temporomandibular joint is the only joint the dentist deal, and it is sometimes we find very difficult to manage patients with say TMJ pain or TMJ noise. So it becomes difficult sometimes to know how to go about treating such patients. So we have with us Sir to tell us about it. Just a formal introduction for Sir by a postgraduate, Dr. Anamika.
Thank you so much, sir. Good morning, everyone. The speaker for our today's webinar is Dr. Kaustubh Sansare. Sir has completed his BDS and MDS in Oral Medicine and Radiology from Nair Dental College, Mumbai. He worked as an associate professor in the same institute. Sir is known for his astute publication at international journals and also presented and invited as a speaker at various national and international conferences. His long-term interest is in understanding and treating TMJ disorder with special focus on infections in TMJ. He has publications in journals like DMFR, International Journal of Oral and Maxillofacial Surgery, British Journal of Oral and Maxillofacial Surgery, Clinical Oral Investigations, and many more. He is also a reviewer for DMFR, Imaging Sciences in Dentistry, Oral Radiology, and Oral Diseases. So please join me in welcoming Dr. Kaustubh Sansare, sir. Sir, over to you.
Yeah. Thank you for the introduction, and thank you so much for having me. And moreover, I apologize for the delay because it has been a little some technical issues from my side, which has caused this delay. So, I'm really sorry for for this delay. At the same time, I am glad that you have invited me for this lecture. So let's begin with it. Like basically, my topic is going to be TM joint disorders caught in controversy. I hope you can see my screen and hear me clearly.
Yes, sir.
Yes, sir.
Okay, fine. And I am going to tell you in the midst of our lecture why I call this as caught in controversy. Right now, we will just begin with it. So basically, this lecture is going to give you a broad outline on TM joint disorders. Basically, I was told that this is going to be a lecture for private practitioners and BDS students, something like that. So when I started with it, I started preparing from BDS point of view. But when you are into teaching MDS students, it becomes very difficult for you to contain your lecture only for BDS. So finally, it just spilled out, and finally, I think I have more points for MDS as well. And recently, sir told me a few days back that there are a lot of MDS students also joining. So I'm happy that it is probably catering to both BDS, MDS groups as well as private practitioners. So it's going to give you a broad outline on TM joint disorders. It's going to help you in diagnosing various TM joint disorders which you will be seeing in your clinical practice. And this lecture will also tell you when to consult an oral medicine specialist for your TM joint disorder case. Okay, so excuse me, because sometimes I may sound that as if I'm only speaking to BDS crowd, but it's been because I have been trying to contain it to BDS, but it has definitely spilled over. You will see it in the course of the lecture. So to give you just a broad outline of what is a TMJ and what is a TMD. A TM joint is a temporomandibular joint, and a TM joint disorder is TMD. Okay, so it contains of the various TM joint disorders which may affect the masticatory muscles, which may affect the TM joint structure, or it may also affect the associated structure of the TM joint, or it may affect both TM joint as both. It can be both arthralgia as well as myalgia. Myalgia is pain in muscle. Arthralgia is pain in joint. Okay. So basic difference between what is a TMJ and what is a TMD. Okay. Now I find this quote very interesting. It's from Okason, who says that TM joint disorder is a complex and multifactorial condition, and so also are our patients, which is quite true, because when you see multiple TM joint cases, you understand that this topic itself is a very complex topic, and therefore I say that it is caught in controversy. And as you see some of the cases, you will come to know why it is caught in controversy. A gross classification. I'm not going into details of all this, but this is just a gross classification, and all those headings which are highlighted in red, all those lesions or all those disorders which are highlighted in red is what I am going to talk about. The others I might just skip because you may not see most of them in clinical practice, like maybe myalgia, disc derangements, dislocations. Another common thing, most private practitioners or most BDS practitioners, then they get perplexed after seeing a case of dislocation in their own practice, and it becomes difficult to handle such a case. So yeah, dislocation, subluxation, osteoarthritis is what we are going to talk about. In fact, if you ask me, I feel osteoarthritis, that is degenerative joint disease, and disc derangement, these forms, along with myalgia, these forms the mainstay of TM joint disorders. Apart from that, yes, you may occasionally see some cases of fibrous bony ankylosis. You may occasionally see some cases of hyperplasias, condylar hyperplasia. More than hyperplasia seems to be more common. So I'll be touching upon these cases as well along the course of the lecture. A little bit of anatomy first. So on the left side of the screen is a closed mouth position of TM joint. Here, if you see carefully, what happens is that the disc is basically a tissue, a structure which is present between the condyle and the glenoid fossa, and it has a middle compressed zone, which generally is at 1130 position to the condyle. So if you draw a straight line from the condyle along the long axis of the condyle, and the disc is usually at an 1130 position from that. So yeah, and when in open position, this is very important because this is what will help you understand what is disc derangement with reduction and without reduction. When in open position, the disc and the condyle usually moves together. The disc condyle apparatus usually moves as a unit. So if this thing gets affected, if the movement of the disc condyle unit gets affected, then it leads to TM joint, then it leads to some of the TM joint disorders. Okay. Now here I'll show you a short clip which will probably give you an idea of how the disc moves. Here, right in the center is the disc, the central compressed portion, the anterior band of the disc, the posterior band of the disc. Some authors also describe the disc as a bow tie appearance. It's almost a bow tie appearance. And once the disc is in open position, this is the retrodiscal tissue which is holding the disc as well. Okay, and the condyle in the open position is almost over the glenoid, almost over the articular eminence. Okay, so, or sometimes slightly ahead of the articular eminence. Okay, so this is how a normal joint would look like in both opening and closing positions. Now, some radiographic anatomy of CBC of a TM joint. Generally, we take two radiographs to diagnose TM joint disorder case. One is a CBCT, in which you just study the hard tissues, and the other is an MRI, in which you study the soft tissue. Now, which soft tissue is important to understand or to identify a TM joint disorder? It's MRI. It's the disc, sorry. So first, these some landmarks on the CBCT. As you all know, this is the condyle. The first, the extreme left-hand picture, it's a sagittal image. Then the next to it is a coronal image, and finally the axial image. The number 9, which is depicted here, is the condyle. 4 is the glenoid fossa, and 3 is the articular eminence. And the same holds true for the other pictures as well. Okay. Some landmarks on an MRI. It's very important that you differentiate a CT or a CBCT from an MRI. Now, most of my pictures you will see are maybe CBCT and not CT scan. That is because we use a lot of CBCT these days than CT scan. Wherever there is a possibility to use a CBCT, we usually use a CBCT. In fact, yeah, I'll come to that a little later. Yeah, so the same thing here. The number 9 here is the condyle. Okay. The number 6 here is the intermediary, the compressed zone of the disc, followed by 1, which is the anterior band of the disc. And yeah, of course, the 7 and 8 is the pterygoid muscle as a unit, pterygoid muscle completely. But 7 is the pterygoid muscle, 8 is the lower head of the pterygoid muscle, and 15 here is the upper head of the pterygoid muscle.
I have brains, right?
1 minute.
Okay, 13 is the posterior disc attachment. So this is about the anatomy, MRI anatomy of the TM joint. I think I already talked about this, so I'm not going to go into details of this. Assessment. How are you going to assess the TM joint? The most important part is the case history, the clinical examination, investigations, and of course the radiographs. Now, if you see the bullets here are different from radiograph to the other points. And that is because I feel that case history, clinical examinations are more important than are equally important to radiographic examination. Usually what happens, most students do a very brief case history and a very brief clinical examination and directly jump over to radiographic examination. But first, whenever I look at a case, I try to check the patient clinically more thoroughly and try to have a provisional diagnosis in mind and then go and take a radiograph. Okay. Now there are certain terms which are commonly used, like one is an open lock and one is a closed lock. One thing you should remember is open lock is when the patient is not able to close properly. Closed lock is when the patient is not able to open completely. Okay. So open lock is very simple. Open lock is commonly seen in dislocation subluxations, where the patient finds it difficult to close the mouth. Closed lock is when the patient finds it difficult to open the mouth completely. which may be seen in osteoarthritis and disc derangements. Okay. Of course, in ankylosis also you get closed lock. One more important point, deviation and deflection. Now there is usually most professionals or most students, they call when the mandible deviates from the midline on the open position, they call it as deviation. Okay, but there is a difference between what is deviation and what is deflection. Deviation is the movement away from the midline during opening without return to the center during the movement. That means that the condyle doesn't come back to its normal position. Or sorry, the mandible doesn't come back to the midline, even after complete opening of the mandible. Whereas deflection, it is a movement away from the midline followed by a return to the center. I have a picture here which can help you understand this. Deviation and deflection. Okay, so use right terminologies. Generally, both are identified as deviations only by most people. Okay. And how to palpate the TM joint? It's very important you know how to palpate the TM joint. Generally, you stand in front of the patient, put your index finger right anterior to the tragus, in the pre-tragus area, and that's where you actually feel the condyle. And use your index finger itself. Don't you use 2 fingers, 3 fingers. There are various books which will give you various kind of types of palpations, but the standard palpation is use your index finger and just anterior to the tragus, stand in front of the patient and ask the patient to open and close the mouth. Okay, and then watch for any tenderness, any pain, any differences in movement between right side and the left side. Because you're standing in front of the patient, you also watch for deviation, deflection, and all these things. There are other methods. There is one more popular method which is called as intra-auricular palpation. However, most people don't actually practice it. In fact, even I don't practice it so seriously because it doesn't provide you more information. I think an extra-auricular palpation itself is sufficient. But that doesn't mean I want to put down intra-auricular palpation. You may still do it. It is theoretically needed. And maybe somebody might find that it adds more information to the TM joint disorder. Okay. A broad outline about what are conventional radiographs used in diagnosing a TM joint disorder, and what are the advanced radiographs which are used in diagnosing a TM joint disorder. Okay. I am not going to go into details of all this OPG, transcranial, transorbital, transpharyngeal. You should know when to use a transcranial and when to use a transorbital and when to use a transpharyngeal. I hope you all know, like transcranial is commonly used for during degenerative joint diseases. Transorbital and transpharyngeals are commonly used if there is a fracture of the subcondylar neck. Okay, and of course CBCT or CT and an MRI. Now, you should also know when to advise a CT or a CBCT and when to advise an MRI. If you suspect that the patient is having osteoarthritis or a degenerative joint disease, then always go for CBCT, because CBCT will give you a good heart tissue coverage and a good heart tissue resolution. But at the same time, CBCT has its own limitation towards soft tissues. So if you suspect in disc derangements, or what is also called in the literature as disc dislocations. Don't get confused with this terminology or dislocation. It is also called in literature, in most part of the literature, as disc dislocations. So yeah, if you feel that your case has a disc issue, then you should go for an MR. And if you feel your case has a structural condylar issue, like say osteoarthritis, osteoarthrosis, then you should go for a CBCT. So this is basic thing, that CBCT for hard tissue, MRI for soft tissue. In fact, I left some space here. I wanted to show you how to read a CBCT or how to read an MRI. But that actually forms a separate lecture on this. So we dropped that idea. But one thing I want to tell you here that whenever you advise a CT or a CBCT or an MRI, not just for the TM joint disorder, but for any other cases, you always ask for a CD. Get the entire data on a CD and then go through the data which is present on the CD. Because what happens, when you just see the pictures on the print that is provided along with the report, or when you just see the plates of the CT or the CBCT or the MRI, what you see is only a small part of the entire data. How much images you may be seeing? Maybe some 25 to 50 images on the print. But when you go through how much images are generated, there are at least 350 to 700 images which are generated based upon the slice thickness for both, for all three, that is CT, CBCT and MRI. So when you go through the CD and you scroll the images and you see each and every section, you see the joint from left side to the right side, okay, or from to be more clearer, from the lateral pole to the medial pole. So that helps you in diagnosing the case rather than just seeing some of the pictures. So next time you advise a CT or an MRI or a CBCT, always get it on a CD and open the CD and see it. Because just looking at the pictures, it will only provide you the information that the pictures have. That it will never provide you the information that the scan has generated. So yeah, I couldn't put it here because it took a lot of. It would have taken a lot of time on how to read a CT and MRI. That before we start with actual disorders, I also want to tell you about there is something called as condylar remodeling. Okay, so condylar remodeling is a physiological process. Basically, it is the ability of the condyle to adapt to various kinds of functional demands. Okay, so at a younger age, or in fact at any age, but it is commonly seen at a younger age. At a younger age, somebody maybe a teenager comes to you and he or she says that yes, I have a click and it started last few days. Then my approach is usually that hold on for some time, or I might just give that person a muscle relaxant or something. And I ask the patient to, of course, rest, or rest in the sense, give rest to the TM joint, not to open too wide and not to eat anything hard. And the condyle adapts to the increased demands of the TM, of the occlusion. So basically, condylar remodeling is something which doesn't need any active treatment. Maybe you can do something, but it doesn't need any major treatment. One of the most important aspects of handling a TM joint disorder, or rather handling most oral medicine cases, is to reassure the patient that there may not be anything wrong with you. Okay, so this holds very true for condylar remodeling. You have to identify cases in which it may be just a simple condylar remodeling and may not be something, or may not be some major TM joint disorder. Okay. So identify what is a condylar remodeling commonly seen in younger patients. Okay. I have a case here. Like this female is a 23-year-old female, pain while opening. Patient also had clicking sound, and there was tenderness over bilateral TMJ and masseter region. Okay. The occlusion was perfect. There was nothing wrong with the occlusion. Maybe some amount of rotation of the canine here and spacing between the lateral and the canine. Apart from that, nothing. And in fact, the patient was insisting for a radiograph, so we took a CBCT for this patient. And we found that the condyle seems to be perfectly normal. There is nothing wrong with this condyle here. Okay. Ideally, you should also see that the condyle lies concentric in the glenoid fossa. Okay, if you trace the condylar outline here, it is almost parallel, or it goes concentric with the glenoid fossa. So that is how you know that the condyle is in proper position in the glenoid fossa. The one another thing you should do is also trace this cortical border of the condyle. If this cortical border is intact, there is nothing wrong. It's absolutely normal. No active disease is present. Okay, and that's how we assured this patient that the patient did not have anything. And of course, the patient we had given some muscle relaxant. Patient reacted to that and was fine with it. Some cases of muscle pain, yeah, myalgia, because another important aspect of TM joint disorders are myalgias. A pain of muscle origin that is affected by jaw movement, function, or parafunction. There is history of pain in the muscles of mastication. So you should know how to palpate the muscle of mastications. I mean, all masseter, temporalis, lateral pterygoid, medial pterygoid, you should be able to palpate. And when you palpate, put your gloves on, palpate bimanually wherever it is possible, and then if there is tenderness in the muscles of mastications, along with pain in TM joint, that is tender pain in the preauricular region, then you can suspect that this may be a case of myalgia. Okay. Now, if you read literature on myalgia, it also tells you that it should have trigger zones and those kind of things. But then, to be very frank, I have not really encountered many cases of TM joint muscular pain with trigger zones. So that has been my experience. Like I am going to take you through my experience. Maybe somebody else's experience is different from my experience. So there may be differences in perception. So we should learn to respect each other's perception. So this is another case of another young 17-year-old female, pain in front of the ear, difficulty in opening the mouth since 1 month. There was history of click. There was deviation of mandible towards the right side while opening. And there was tenderness on TM joint pain, both sides, bilateral. So, yeah, of course, you may suspect that this may be a case of remodeling. Yes, absolutely fine. It may be a case of remodeling. But again, this patient also had muscular pain. So we had to take a call on to give muscle relaxants to the patients along with other supportive therapies like soft diet and limited opening, hot water fermentation, etc. So yes, in this case also with the muscle relaxant, the patient got relief and the patient was fine. You may also get myalgia in older age groups. It's not that only in younger age groups you may get myalgia. Now this patient had pain in preauricular region while cough, and mainly is pain aggravated while coughing and sneezing. So yeah, and there was history of clicking, there was attrition clinically. Patient had a habit, if I'm not mistaken, the patient had a habit of chewing tobacco. And that is why there was attrition and there was pain in the muscle. So finally, yeah, we also did the same thing for him, soft diet, limited opening, and hot water fermentation. When you do hot water fermentation, another important point to remember is ask the patient to do it over the joint and around the joint area. Never ask the patient to start doing hot water fermentation anterior to the muscle of mastication. That is the masseter or mainly the masseter. Because what happens then, the patient, while doing the hot water fermentation, the patient starts putting it on the dental areas also. That is the third molar region, the second molar region. And we had a case where the patient then came up with a swelling in that area. And we found that there was an infected tooth over there, and the patient was doing excessive hot water fermentation. And the hot water fermentation was not limited only to the joint and the peri-joint area. It was also being extended to the dental region, and which helped in flaring up the periapical lesion. So you need to be very particularly telling the patient that only around the joint area and on the joint you need to do hot water fermentation, nowhere else. Okay. Some cases of disc derangement. before going into cases of disc derangement, what is disc derangement? Disc derangement is the presence or the displacement of the articular disc from where it should be normally present. So the most common disc derangement is anterior disc derangement. So if you read the literature, most of the disc derangement are commonly anterior disc derangement with reduction or without reduction. Yes, of course, we have cases of posterior disc derangement, anterior lateral disc derangement. I think we also have a case of a lateral, proper lateral disc derangement, anterior lateral, I think. Okay, so yeah, this is about disc derangement. And what is disc derangement with reduction? What happens in with reduction is that when the patient opens the mouth, the disc and the condyle should ideally move anteriorly as one single unit, as I told you earlier. But in with reduction, what happens? The disc is already displaced anteriorly. The disc is not in the closed position. The disc is not in a proper disc-condyle relationship. The disc is already anterior to the condylar head. And when the patient opens the mouth, the condyle comes ahead and then attains a normal position with the disc. So when the patient opens the mouth, the condyle just slips under the disc. And that is how you get a case of disc displacement with reduction. Okay. As I told you, yeah, it may be medial or lateral displacement also. Along with anterior, it may also be medial or lateral displacement. Another important thing to remember, of course, I will be covering up this point also later. But another important thing to remember is that sometime or other in cases of disc derangement, either there is a current click or there is a history of click. Sometimes what the patient tells you is that there was clicking earlier, but now it is not there. Okay. So there may be history of click. If there is a history of click, you may be almost 90% sure that it is a disc derangement case. Okay. Because the other important group of TM joint disorder, which is the degenerative joint disorders, which basically leads to crepitations and not clicking. And you should know what is the difference between a clicking and a crepitation. Clicking is a sharp sound. It is a tuck sound. Okay. And crepitation is a rough, it's like a rough rumbling sound. Okay. It's not a very sharp sound. And it is, I don't know how to explain, but it's not a very sharp sound. It's a little dull sound. Clicking is a single sharp sound. You may have double click, you may have reciprocal click, may have different types of clicking also. But one thing you should remember is that when there is history of click, it almost sure shot points to disc derangement. Okay. There may also be deviation of jaw if it's unilateral. But if it's bilateral, usually deviation doesn't occur. So we have here a case of disc derangement with reduction. Here's a case of 23-year-old male. Patient had pain on right TMJ region and reduced mouth opening since 3 months. Now this is not transient. The remodeling cannot continue for 3 months. This was not transient. So the patient had pain and reduced mouth opening for 3 months. There was history of pain on opening and history of clicking. Now that's what I was talking about. History of click. There was no current click. Deviation was there towards the right side, and there was tenderness over the right side. Of course, his MRI was taken, and this is what the MRI shows. On the closed mouth position, this hypodense area is the disc. You can see a bow tie appearance here, which is pointed out by this yellow arrow on figure A. This hypodense area is the disc. Now this is closed mouth position. You also need to identify the the auditory meatus here, the external auditory meatus. Okay, and just anterior to the external auditory meatus is the condyle. And this again hypodense outline of the condyle is the cortical border of the condyle. So the condyle seems to be okay in structure. but the disc is anteriorly displaced here in closed mouth position. When the patient is asked to open the mouth, see the distance between the auditory meatus and the condyle. It's grossly increased. Sometimes you see that the movement is also reduced, and there is hardly any movement of the condyle in the open position also. It may not be so clear every time, and that is why I called it as caught in controversy. It's not always so clear. And here you can see that the compressed zone of the disc is right over the condylar head. So the disc condyle relationship in the open position is normal, but in the closed position there is anterior disc displacement. So this is anterior disc displacement, but with reduction. Okay. Now why did I put this PD? Okay. So yeah, this is a proton density image. Now, if you go through the literature, like I think I didn't tell you this earlier. Yeah, when you advise an MRI, always advise an MRI. Of course, the MRI technician or the MRI doctor, the radiologist will always take a T1 weighted image, a T2 weighted image, and a PDW weighted image, or proton density weighted image. Okay, so technically, a T1 weighted image is always used for anatomic structures to assess the anatomy. Now, the joint here the disc here is an anatomic structure. It is only displaced from one position to the other, but there is no pathology with the disc as such. And that is why T1 weighted image is always used to identify disc displacement. Okay. But there have been articles in the literature which says that more than T1 weighted image, it is the proton density image which gives you more clarity on the disc. And I think I have a picture ahead which will show you how it is a T1 PDW images are much better than T1 weighted images. And of course, when you want to study the fluid, you take a T2 weighted image. Fluid, when do you see fluid in the joint? You only see fluid when there is an effusion. Okay, effusion is seen when there is an inflammatory process. Okay, so when you suspect that there is an inflammatory process, you always take of course, the radiology technician or the radiologist is going to take all these images. So when you see a bright image or a bright spot on a T2 weighted image, you know that it is effusion. We have pictures about it, so let's not get confused. In this case, it is anterior disc displacement with reduction on a proton density image. And of course, this was what was done for the patient. In fact, this was one of our latest case in which we had tried PRP injections in bilateral TM joint. In fact, we don't have a much follow-up for this patient. I think 1 month or 2 month follow-up is there. Because this is one and only one case in which we have tried PRP for both the joints. Okay, we have been trying something called as hyaluronic acid for TM joint injection, for internal disc derangements also. Okay, so we'll come to that. Another thing that you should remember is that, see, not all disc derangements will always manifest with pain. There are in this article, if you go through this article, I think it was in the year 1997, but there are articles much later than that also, which says that asymptomatic patients also has internal disc derangement. Okay. So it's not that maybe most of us, we have internal disc derangement, but we don't manifest with pain. And some of us may manifest with pain. In fact, it is said, according to a conclusion of this article, that something up to 15 to 30 degrees of derangements, of disc derangement should be considered as normal. Okay. Anything which is beyond the 1130 position up to 15 to 30 degrees should be considered as normal. So sometimes, I have students who tell me there is only slight disc derangement or slightly it is anteriorly displaced. So I can tell them that you should consider this as normal. Very slight derangements are not supposed to be interpreted as pathology. So yeah, the next thing is without reduction. Without reduction in without reduction clock, what exactly happens is that the disc doesn't come to lie in a normal position to the condyle in the open position. In the open position, the disc is still anteriorly displaced. It doesn't get reduced. It doesn't get reduced means it doesn't become a normal condyle disc relationship in the open position. I hope this is clear. There is a history of lockjaw, limited mouth opening, and inability to eat properly. Okay, this is what I was telling you about anterior disc displacement without reduction. Now, this is a condyle here. You can see the condylar structure. If you see the condyle clearly, you can see that there may be some slight flattening here, okay, on the posterior aspect of the condyle. Then this hypodense area is the disc, okay. And when the patient opens the mouth, basically there is hardly any movement. The patient, even though the patient opens the mouth, the condyle is not much anterior to the glenoid fossa, and the disc is still there only. The condyle disc relationship is not normal in the open position also. And that is when you call it as disc derangement without reduction. Okay. And this is what I was telling you. Now, this is a T1 weighted image. You see the disc here. The disc is still seen clearly. It's not that the disc is not seen clearly, but you just compare it with the proton density image and see the clarity of the disc. So, yes, there have been articles in the literature recently which says that proton density images are much better than T1 weighted images in assessing the disc. Okay. So, yeah, when in the exams you are asked about which is a better image to assess the disc, and you can even answer proton density image along with T1 weighted image. Okay. Now, here we had a patient. She was a 50-year-old female, pain in the right and left ear region since 6 months. History of clicking sound. Again, mind you, history of click. Tenderness over the TM joint bilaterally. And if you try and trace the midline of the upper jaw and the lower jaw doesn't coincide. Okay. I think I have a close-in picture of this. No. Anyway. Yeah, a proper close-up picture of the oral cavity would have given you a better idea. Because, I have orthodontic friends who tell me that 3 millimeter of deviation is supposed to be normal. I mean, orthodontically, they don't consider 3 millimeter deviation as any abnormality. And that may be absolutely right from ortho point of view. Or even in medicine or radiology point of view, we may not consider mild deviation as a great deviation. But along with that, if it is supported by the MRI, showing a disc derangement or any other TM joint disorders, yes, then you need to consider it as a TM joint disorder. Here, if you see, this is a T1 weighted image, right side. This is the condyle, external auditory meters, and you can see the disc here. If you see here, yeah, see the disc is here. Now, when the disc gets so anteriorly displaced, it's really, I mean, sometimes when I see only the closed mouth position, I generally tell myself that the disc is not going to get reduced on open mouth also, unless the patient really has an hypermobile joint. But when the patient has disc derangement, as I told you earlier, most of the patients also has limited opening. So that it's when the disc is so anteriorly displaced, generally I come to a conclusion that the disc is not going to get reduced on open position also. This is a T2 weighted image. Another point I want to make here is you should know how to differentiate a T1 weighted image from a T2 weighted image. Now, if you see, this is the brain tissue here. Okay. And the brain tissue shows the gyri of the brain. Okay. And this is a T1 weighted image because the subcutaneous fat is bright. Okay. And this is a T2 weighted image because the fluid is bright. Fluid is bright in the sense the CSF has stood out. The CSF is hyperintense, and that is why it is a T2-weighted image. And if you're assessing the joint and you see a hyperintense area here in the joint region, it's just like anterior to the joint. This may be a beginning of joint effusion. You can see that there is some amount of joint effusion here. It may be beginning of the joint, it may be beginning of an inflammatory process. Okay. As you can see here also, the CSF is also bright and there is a bright spot here. Okay. So beginning of joint effusion. And yeah, in this particular case, there was, I think there was left side disarrangement without reduction. One side was with reduction and one side was without reduction, which makes such cases so unique. And that is why I labeled it as caught in controversy, because it may be that, yeah, as you see that the right side, I think there was anterior disc displacement with no evidence of reduction. And on that side, there was anterior disc displacement with evidence of reduction. So you may have a same patient having two different conditions. And that is why it's controversial. Yeah, I was talking about another important thing I want to tell you is that I have found good amount of success. Of course, we have not done any study, but good amount of success with Dolonex. Dolonex DT is nothing but piroxicam. And it has, and there are literature supporting it, because the piroxicam has a ability to penetrate into the synovial fluid. That is why piroxicam helps in relieving TM joint pain much better. So you may consider next time prescribing piroxicam also. Of course, injection, as I told you earlier, we are doing some cases where we are injecting hyaluronic acid into the joint. Again, we don't really get, we get two kind of hyaluronic acid solution. One is an ophthalmic solution and one is an orthopedic solution. And basically, I spoke to both the ophthalmologists and the orthopedicians, and they tell me that there is no big difference within the two solutions. You can use anyone which is available. And action of sodium hyaluronic acid is that it improves and restores normal lubrication in the joint, provides nutrition to the avascular articulating disc, and stabilizes the joint. So it can, because it provides nutrition and lubrication, it also helps in treatment of osteoarthritis also. And you may find this kind of literature in the journal, wherein it has been used for both disc derangements as well as osteoarthritis. Now, there are certain complications these kind of disc derangements can lead to. Like it can also lead to what is called as crumpled disc. Now, this disc doesn't have its normal shape. It's almost like an inverted C shape. So it can lead to crumpled disc. It also shows that there is a bright marrow edema here. Okay. So these are the complications that can occur. There's something called a stuck disc syndrome, in which what happens is that if you see this position, the disc seems to be normal. The disc seems, this hypodense here, structure here is the disc. The disc seems to be normal to the condyle. But when the patient opens the mouth, the disc is still there only. The disc has not moved anteriorly with the condyle. So the disc has remained there. And when does this happen? When there are adhesions of the disc to the glenoid fossa. The disc then refuses to come out of the glenoid fossa, and it is only the condyle which moves ahead. And when do we get adhesion? When the synovial fluid loses its viscosity. The synovial fluid would lose its viscosity with age. So stuck disc phenomenon is generally seen in an elderly patient. If you see the condyle here, you may see that it has a slight amount of flattening also. Okay, so which again makes it clear that this may be an elderly patient. So stuck disc phenomenon commonly seen in elderly age groups. So these are some of the complications. We had an interesting case in which the disc, initially when the patient came to us, there was a reducing disc. As you see here, the disc is almost in the normal position with the condyle, okay, on an open position. And when you and after 10 years, when the patient again came back to us for the TM joint pain, the disc from reducing disc became to was turned into a non-reducing disc. That is, disc displacement with reduction became disc displacement without reduction. Of course, in this particular case, in this particular picture, you can't see the disc very clearly. Yeah, we had reports suggesting that the disc displacement is now non-reducing. So it took 10 years for the patient from reducing disc displacement to non-reducing disc. And with this, we come to another important point that some of this disc derangement which remain chronic may also turn into degenerative joint disease. I don't think so. We have a case about it yet. No. So some of these disc derangements can also become degenerative joint disease. Some of the degenerative joint disease may also lead to disc derangements. And that's where is the TM joint is so unique and so complicated. And that's where the controversy begins. So that's why I labeled it as caught in controversy, because there's so many things which you see which are not given in textbooks. Now we come to degenerative joint disease. The joint is characterized by deterioration of articular tissue with concomitant osseous changes in the condyle and or articular eminence. The definition itself is concomitant osseous changes in the condyle. Now, what are the osseous changes that are seen in the condyle? It's erosion, the condylar erosion, condylar flattening, okay, Ellis cyst or subarticular cyst. Some changes which are seen in the articular eminence along with the glenoid fossa. Some changes in the articular eminence along with the glenoid fossa is sclerosis. There is also some osteophytes which may be seen on the condyle. And when these osteophytes break off, they present themselves as joint mice. So there are multiple changes which are seen in degenerative joint disease. Okay, and all this needs to be assessed. Some of these are considered as early markers of degenerative joint disease, and some of those are like your joint mice may be considered as a late marker or an advanced stage of degenerative joint disease. We first come to the most important component of degenerative joint disease, that is osteoarthritis. Okay, let's not go into details of all this. Yeah, here I show you some pictures of osteoarthritis. Okay, now if you see this condyle, it looks like as if like a beak of a duck. Okay, you see this picture here. You see this picture here. It again looks like a beak of maybe another animal or maybe another bird. A thicker beak, a thin beak, thick beak, a very blunt and a very small beak. Okay, so these are osteophytes. So, and these are osteophytes. Some people also refer to as lipping. Extreme flattening of the condyle. Extreme flattening of the condyle. So these are basically some of the manifestations of osteoarthritis. As I was telling you, osteophytes are also osteophytes are also seen as manifestations of osteoarthritis. And when do you know that there is erosion? If you ideally, I always tell my students that you should trace this cortical border of the joint. And when you see that there is break in the cortical border, it is erosion. When the cortical border is not uniform and it is like flattened in certain areas, I don't have any slide for flattening here, but I have later in course of this lecture, I'll show you. Then then it should be considered flattening. Flattening may not be always associated with erosion. It may or may not be always associated with erosion. So erosion and flattening, you should be able to differentiate. Of course, osteophyte and subarticular cyst is also present. Sclerosis of the glenoid fossa and the articular eminence may be seen. These are some of the other changes. We have some cases again. A 44-year-old female, inability to open mouth since 4 to 5 months. There was crepitation, and this again you see this female. This is an elderly patient. Elderly patient should be considered for degenerative joint disease. Younger patient may be considered for disc derangements. This is not a thumb rule or a definite rule. You can't compartmentalize things like that, but yes, more or less it falls into these age groups. So elderly patients, yeah, as I said, degenerative joint disease, mouth opening, inability to open mouth since 4 to 5 months, history of crepitation. Crepitation again is commonly associated with degenerative joint disease as against clicking, which is associated with disc derangements. Tenderness and crepitation over TM joint bilaterally. Let's see her OPG. We took an OPG and this is what we found. There was osteophyte here. There was flattening. See, there is flattening here. This is flattening. This is flattening. But this is flattening without erosion. Okay. So the cortical border is intact, so it is flattening without erosion. Okay, so yeah. We took CBCT for this patient and you see this flattening and osteophytes in various stages, right? From small to a very huge and large osteophyte. Okay. So this was a case of osteoarthritis. There was another one, a 65-year-old female, again elderly patient, pain in the TM joint region, chewing since 1 month, history of clicking, tenderness over the right TM joint region, crepitation over the left TM joint region. Okay, let's see the OPG. See, the entire shape of the condyle is gone. The condyle has been like not concentrically present in the glenoid fossa. There is some amount of thicker osteophyte here. Okay, some amount of lipping is seen here as well. Okay, if you see her OPG, see this OPG, this completely flattened teeth. See this posterior here, absolutely flattened. Probably these have not been flattened because the lowers were missing here, but otherwise from anterior to posterior, absolutely flattening. Okay. So this was another case of osteoarthritis in which, we also did soft diet. Generally, we usually try with conservative treatment. We don't want to jump and start giving injections to the patients. So we start doing conservative treatment, soft diet, limited opening, hot water fermentation, muscle relaxants maybe so that the patient gets relieved of pain, because most muscle relaxants are also associated with anti-inflammatories or also associated with painkillers, non-steroidal anti-inflammatory agents. But this didn't help. Then we also asked the patient to take Inosite, which is indomethacin, for 25 milligram for 1 month. If that also doesn't help, because if you see the most patients with osteoarthritis of other joints like knee joints, they don't really react to indomethacin in a big way. So most patients of osteoarthritis remain patients of osteoarthritis for a longer time. And then we also injected sodium hyaluronic acid twice for this patient, and the patient was fine. Now, if you see along the course of my presentation, we have not injected steroids anywhere. I want to make I want to state a word of caution over here. As far as possible, refrain from injecting steroids. Early in my career, I had done it. I was very fascinated by steroid injections and the results that it used to give. But then as I evolved, I would say, I started reading about it and I found that steroids can also lead to erosions in the condyle and flap. Most probably erosions of the condyle, and it can lead to further complications later on in life. So that is why these days we have almost, I don't remember when was the last steroid injection given by me or any of my students. So don't blindly inject steroids in the joint. And if at all you are injecting for any purpose, in a lifetime, don't inject more than 3 doses of steroids in the joint, because it leads to joint erosion, joint flattening, and it leads to further problems for the patients. Okay. Some of the complications of osteoarthritis. Now, as I told you, these TM joint disorders, it's very difficult to compartmentalize TM joint disorders into particular groups. Like if you see here, we had a case of osteoarthritis with anterolateral disc derangement. Okay, this is the external auditory meatus, this is the condyle, and this is a disc. There was deformity of the condyle, and there was disc derangement also. So you get a combination of this kind of cases, and that's where the controversy lies. And that's this, when we took a coronal picture, we saw that the disc was not just anteriorly displaced, but was also anterolateral displacement of the disc was present. Now, if as I told you earlier, most of the times the disc is anteriorly displaced, but you may also get cases where disc is anteromedial or anterolateral displacement. Very rarely will you get a case of posterior disc derangement. Of course, I think we have some cases of, we have one case of posterior disc derangement also. Yeah, I think it's here only. So this was osteoarthritis. See the shape of the condyle here. Completely deformed, flattening. Erosions, of course, cannot be studied on this, but there is flattening here, and the disc is displaced posteriorly. The disc here is posteriorly displaced and crumpled. Okay, it has lost its shape also. So these are some of the complications: osteoarthritis and anterolateral displacement with joint effusion. It's the same earlier case where I think I should have put it next to each other. It would have been earlier easier for you to understand. It's the same this case in a T2 weighted image. Now just see the brain tissue. There is no CSF which is standing out. The subcutaneous fat is standing out here. So this is a T1 weighted image. And you don't see any fluid around here. But the same image is T2 weighted image. You see it's fluid. I think this is a proton density image. It's not a T2 weighted image, in which you can see this fluid standing out, and there is effusion in the joint space in the TM joint. You can't call it as a joint space, but generally it is said that effusion is commonly seen in the superior joint space. Since the effusion is seen superior to the disc, it is in the superior joint space. Had it been seen inferior to the disc, it is in inferior joint space. Okay. Now, to give you a gross outline about how to differentiate between disc derangements and degenerative joint diseases or osteoarthritis. A clicking sound is commonly present in disc derangement. Some of these points I must have covered earlier. Clicking sound or history of clicking sound is commonly seen in disc derangement. Crepitation is commonly seen in osteoarthritis cases. Okay, so this is a big difference. And if you are able to identify a click from a crepitation, you will, at this point only, you will be able to differentiate between the two conditions. Deviation or other irregular jaw motion on opening, which is commonly seen in disc derangement. Whereas osteoarthritis, since there is a structural abnormality in the condyle, and most of the times it is both the condyles which is getting affected together, it just restricts the oral opening. It may lead to deviation, but these are just gross outline of how you may differentiate. This may not be a strict outline of how to differentiate between each other. So yeah, most of the times what you see is restricted oral opening. And deviation is most of the time what you see in disc derangement. Okay, there is pain or no pain in the joint and or the muscles of mastications in disc derangement. Pain or no pain in the joint and muscle of mastication in osteoarthritis. These are common findings for both disc derangement and osteoarthritis. Radiographic features: disc displaced, and it may be normal or deformed. Disc is displaced, but there is degeneration. There is degeneration of the condyle, or degeneration may be present in osteoarthritis. Cortical bone is normal, whereas you get cortical bone erosion in osteoarthritis. Effusion, typically located in the upper joint space, is seen in disc derangement. Joint effusion is seen in early or in late stages of disc derangements. Some of these findings may not help you in complete differentiation, but yes, there is flattening, sclerosis, osteophytes, subcondylar cyst, which is commonly associated with osteoarthritis. None of these findings are seen in disc derangement. Bone marrow edema is commonly seen in the condyle in disc derangement. Bone marrow edema or bone marrow sclerosis, both are commonly seen in combination in osteoarthritis. Yeah. Again, I want to put in a disclaimer here that this may not be features which will help you in exact features which will help you in differentiation, but it will give you a guideline of how to differentiate between the two. A small break here. If you can see this picture, this is a CBCT of a patient, and this is not a TM joint picture. But I find I have an inclination towards radiology. So I found this picture very fascinating when I was recently scrolling through one of the CBCT. And if you can see this molar here, the cross section of this molar, it resembles a human face, and which really fascinated me. And I scrolled it around, and I saw that it gave different expressions, a smiling expression, a crying expression, and in fact, I had asked my PG to put in a presentation called as expressions, but of course we couldn't manage that. So coming back to our topic for today, another important aspect is dislocation and subluxation. And I have seen practitioners or even PG students who get perplexed when their patient lands up with dislocation on the chair. I don't need to go into detail about all this because you all may be knowing what is a dislocation and how to differentiate dislocation from subluxation. In short, subluxation is chronic dislocation. That is, a patient gets dislocated mandible, but on his own he is able to put it back to normal, the subluxation. And dislocation is something which the patient is not able to put the mandible back to normal. Okay, and he needs an operator or assistance from the dentist. So we had this 80-year-old female with dislocation, which she had frequent dislocation of the jaw since last 1 year. Jaw reduction was done frequently. We used to do jaw reduction. The patient used to come back to us again and again. And I would like to show you this picture of this patient. And if you see, what we are doing here is nothing but autologous blood injection. What we usually do for frequent dislocations is we withdraw patient's blood and around 1.5 cc's and put it in the joint space. And most of the time I usually put it in the superior joint space. And it leads to heme arthrosis, and this heme arthrosis leads to limited opening. Okay, and that leads to reduction in, not exactly reduction, but reduction in the episodes or the frequency of dislocation. Now you may watch this video when I'm withdrawing this blood. Okay, and if I'll show you one more, we'll stop this video here. Okay, maybe you can see. It's very important how to withdraw blood also. I mean, if you're not aware of it, don't do it. And then play this video also simultaneously, in which you can see that the blood will be injected in the joint space of the patient. But you know what? I need to tell you that this was one case in which we really actually did not succeed. The patient had come to us often again and again with this dislocation. In most of my autologous blood injections, we had good amount of success. We had really good amount of success. But in this case, we didn't really succeed much. Maybe because of laxity of the ligaments or of the muscles, or articular eminence was completely flat, and we couldn't just. If you see here, I'm injecting in the superior joint space, and sometimes then I inject in the peri-joint space also, or the intracapsular area. We have another case here of a 75-year-old female who had a lockjaw, who had another case where there was frequent dislocation of the jaw, and since only 15 days. This was her OPG. See her OPG. I mean, sometimes it becomes interesting to take an OPG first and then see. Because if you see the OPG, I don't know, on this side, maybe you can see the glenoid fossa, the articular eminence, and see where the condyle has landed. It's almost on the. I mean, it's much ahead and much superior to the articular eminence. So if you want to take this down, this kind of cases can become complicated because first thing, you don't have the support of the teeth to hold the mandible and take it down. I'm not going to explain you how to reduce this dislocation because I'm sure some of you must be knowing, or most of you must be knowing about how to do it. But because you don't have support of the teeth to take the mandible down, it becomes difficult to take it down. Not just take it down, you also have to take it behind and then put it back here. So you have to take the mandible this much down, that is around maybe 1.5 centimeters down. So these are difficult cases to manage. The jaw was reduced and put back to normal, and we had given thread bandage. And then, of course, we had done autologous blood injection for this patient also. And this is the same patient in which you see that the condyle is back in its normal position. Okay. Another case of a younger patient, 25-year-old male with intermittent lockjaw. His episodes were not so frequent or so. The frequency was much less. The lockjaws once in a month. It was maybe only once in a month. But that old lady of 80-year-old, I remember she used to come every 8 days, 15 days at least once. Deviation of mandible towards the left side while opening. There was, I think, the bilateral. Yeah, he had a bilateral disc derangement. At that particular point, our OPG machine probably was not working, so we had taken transcranials, closed mouth and open mouth, and you see the amount of hypermobility. It's not, generally the condyle should have rested here over the articular eminence. It's gone way ahead of the articular eminence. In what? In just see this distance. See the articular eminence here and see the condyle here. In just about at 25 years of age, this patient has a condyle which has so much of hypermobility. In fact, I remember in one of my cases, I measured the opening and in the hypermobile position, and it was something around 62 millimeters, which is like strange. And he was a young engineering student, I remember that. So yeah, we had also done autologous blood injections for him. Some other group of cases, ankylosis. I'm sure you would be knowing how to identify ankylosis. You need to see the condyle here, and you need to see the glenoid fossa. You need to see the same structure on the other side. And when you see a huge radiopacity there, you can't trace the condyle, you can't trace the glenoid fossa. Many a times you can't even see the articular eminence. Then you know that this is a case of ankylosis. Of course, it may be a case of a tumor over the joint, over the condyle or the subcondylar area as well. We have another case here, a 12 years old female with reduced mouth opening since 3 years, history of trauma, tenderness over the right TM joint region, deviation of mandible. Mouth opening was only 13 millimeters, as you can see in this picture. Now, if you see this, the right side condyle is the condyle is not very clearly seen. There is an osseous structure which is projecting over the condyle, suggestive of bony ankylosis. You also need to differentiate between the bony ankylosis and fibrous ankylosis. I think I had a case of fibrous ankylosis. I didn't put it up here. I'm sorry for that. Then another group of cases is condylar hyperplasia. And this was another interesting case. I think we had this case only maybe 8 days back or 10 days back or something like that. And I can tell you how this case was presented to me. And this, I think the patient had complaint of pain in 1/6 or something. Yeah, here it is. Patient had pain in 1/6, POP positive. And then since because of COVID, we are not taking intraoral radiographs, I asked the student to take an OPG and show it to me. And yeah, this OPG was then shown to me. I said, yeah, there is something wrong with 1/6 because the filling is or not 1/6, it was probably 1/7. I don't remember exactly. Yeah, some dental complaint this patient had, and when I saw the OPG, you see this OPG, the patient, the right side height of the ramus. Compare it with the left side height of the ramus. This height of the ramus is much shorter as compared to this. This was the first thing I noticed. Then I saw that the neck of the condyle also seems to be elongated. The neck of the condyle is almost normal out here. Then I saw that the midline is also not coinciding. And the patient's age was 35. So the patient has already crossed the growth spurt age. Okay. And then I asked the PG student to see the patient intraorally, and then they found that the midline was also not coinciding. Not just that, there was a crossbite. Then I told the patient that the patient had a mild. Sorry, I told the student that the patient had a mild condylar hyperplasia, and it did not really affect her aesthetics so much, so she did not bother about it. And now, since the growth spurt has stopped, it is not growing anymore. So this was an interesting case of, the patient did not come with a case of condylar hyperplasia, but was identified as a case of condylar hyperplasia. I hope you appreciate that and understand that. Sometimes you also get some incidental findings of TM joint disorders. Okay. Like in this particular case, 58 years old female, you see that the left side condyle is absolutely normal and the right side shows osteophyte. Okay. So some findings which are suggestive of osteoarthritic changes being taken place on the right condyle. Another similar case where you again see a osteophyte here in the right side. Now you don't try to jump into conclusion that this ramus side is also different. No, you also need to see that where is this condyle lying. This condyle is lying at a much lower level from this condyle. The patient's position here, the teeth position, this teeth position, the third molar here is at a much higher level than the third molar here. So the patient probably was not placed properly in the OPG, and that is why you see that there is a discrepancy from right side to left side. Whenever you see these cases now, it's not that directly you jump to conclusion, no, this is condylar hyperplasia. No, you also need to compare it from one side to the other side. In fact, I always tell my students that radiology is just a study of comparison. In fact, even I do the same thing. When I don't understand anything, I just compare it with the other side and see if I can find something abnormal over there. Another great and interesting case. This patient had severe pain on the left side. And of course, still this case is still not diagnosed because we are still not able to find why the patient is having pain. And very recently, the patient gave me a call and tells me that there is similar pain on the right side. Of course, I asked the patient to take a proper brain scan because I couldn't find any cause for this particular pain. So I have asked the patient to take a brain scan. I'm not very sure. The patient had gone to many well-known dentists around, and she was completely frustrated with her present condition. And yeah, the interesting part here is that see the amount of bifurcation of the condyle here, the bifid condyle. I have never seen this bifid condyle. I mean, two different subheads of the condyle. And this was just interesting. Of course, it was not something which was relevant to to her complaint. But I was just wondering if there is one single disc or two discs out here. We were not able to trace because the patient had not got the CD. Patient had was referred from somewhere else, and we didn't have a CD for this MRI. So we were not able to find out if there was one single disc or two discs over this bifurcated condyle. And I assume that you can't have a disc which is that huge. And maybe the patient has two different discs. But of course, this is again just academic interest. This is not going to help the patient relieve of his or her pain. In fact, my first impression was, I'll tell you that my first impression was that there is bifid condyle, and probably there is entrapment of the disc in this group, and that is why the patient is having pain. But of course, the patient did not have any TM joint pain. I examined her clearly, and there was no TM joint pain. The pain was in the upper left region. That's all, and it was not neuralgic pain also because I think the very next day I got a call that the other side is also paining. So it was bilateral. Bilateral neuralgias, as you all know, are very, very extremely rare. It's associated with some particular syndrome. I don't recollect which syndrome, but yeah. Now, this particular case now is a case which was again referred to us. I put this as controversy unfold. Means it's continuing on. The controversy still continues. And probably this is one of the last cases we have here. Yeah, it was a 29-year-old. And why the controversy unfold? Because if you see now, there is a lot of discrepancy in this particular case. The pain in right TMJ region and difficulty in opening the mouth since 1 month. There was history of open law since six months back. There was history of clicking. So if you only read this much, you feel that yes, it could be disc derangement. Mouth opening was good, 41 millimeters. Tenderness over the right TM joint region. So it doesn't really fit into description of disc derangement because the mouth openings was quite good. 41 is considered to be good. All these medications were given to him by somebody else. We had just got this case. We had not done anything for this particular patient. And when you see the joint, when we saw the MRI, the joint seems to be absolutely normal. Condyles are normal. The disc condyle relationships seems to be normal. But there is a huge amount of effusion here. If you see this, there's a huge amount of effusion anterior to the condyle. Okay. Inferior joints. Disc is up there and it's in the inferior joint space. If you saw the coronal image, that the same effusion is also laterally present. So there is an anterolateral joint, but the disc seems to be normal. There is no anterolateral disc derangement. Somebody had given Indocid to this patient. I don't know why. For a 29-year-old, Indocid was given. And this is how the controversy still keeps unfolding. And yeah, that's all I have for you. I would like to leave you with this image of a periapical lesion which I saw. This is not something related to TM joint. And when the first thing I saw this radiograph, when the student brought this radiograph to me, I said, this is periapical coronavirus. And if you can see that there is a similar structure of coronavirus in the periapical area. This is, of course, this is nothing to do with the TM joint, just to end on a very good note. Well, thank you so much, Dr. Mishra, for having me here and the entire team. And again, my apologies for having joined a little late because we had some technical issues out here. But I hope I have tried and covered most of it. I have not covered splinting part of it. Splints are something which was quite controversial. So I didn't really cover that part. And in fact, before yesterday, I went through an article on which was a systematic review on occlusal splints on TM joint radiographs, on TM joint disorders. And the conclusion was that there is no evidence as of now to show that occlusal splints are helping. Of course, I do understand and I do respect that some of our own workers have different opinion about it. and some of you must have got good response. In fact, that bifid condyle patient, she had told me that when she is wearing a splint, she gets relief. So yeah, some aspects I must have missed because TM joint is a very huge area, and it's not always possible to cover it. I still went quite long enough beyond my time that was allotted to me. Oh yeah, thank you so much all of you for attending. Anybody has any questions or something, any points or comments to be made, any discussions, we can have it.
Thank you so much, sir, for this very interesting and informative session. Now we'll move towards the question answer session. The first question from Dr. Abhay is deviation and deflection is same as S curve and C curve or different?
Sorry, I didn't get you.
So the first question is deviation and deflection is same as S curve or C curve or different?
No, S curve is when the mandible comes back to its midline position, and C curve is when there is a proper deflection in which the mandible remains deflected at the end of the opening also. So deviation and deflection is definitely not the same. I hope I'm clear about it.
Thank you, sir. This next question is, for deviation and deflection, we have to make maximum mouth opening.
Yes. You have to make maximum mouth opening, only then you will be able to see it. But it should be a comfortable mouth opening. It should not be that you ask the patient to stretch the mouth with pain. It should be a comfortable mouth opening. It should not be a painful mouth opening to assess both deviation and deflections.
Thank you. The next question is by Dr. Shoaib Alam. How we check tenderness of TMJ?
Okay. Tenderness of TM, basically tenderness of anything, any tenderness. Like if you touch that area and if it is paining, and of course with little amount of pressure, then it is tender. So when you are palpating a TM joint, when you are just lightly putting your finger on the preauricular area and asking to open and close the mouth, the patient may not feel that tenderness, but you are slightly pressing that area and then asking the patient to open and close the mouth, and then there is pain, then it is tenderness. Okay.
Thank you, sir. The next question is by Dr. Sulaim. How to diagnose condylar remodeling?
Okay. This is a tough one because generally what I do is when the patient is young and the patient responds well to the conservative treatment, that is hot fomentation, soft diet, limited opening, and a muscle relaxant maybe, and the patient doesn't come come back to us after the treatment with the same amount of pain again, then it is condylar remodeling. And moreover, it is a younger patient. Moreover, it is a patient who doesn't have any structural abnormality with the condyle. Then you may consider it as a condylar remodeling cases. As against a patient who may even though is a younger patient, you may see that the patient keeps coming to us again and again with the same amount of pain. Then in that case, it may not be considered as a condyle, even though the patient is young, it may not be considered a condylar remodeling case. So a young patient who responds well to conservative treatment, doesn't have any recurrence of the same pain, is condylar remodeling. I hope this is clear.
Yes, sir. The next question by Dr. Abhay is, what are the indication of hot and cold fomentation?
Okay. Generally, I usually prescribe my patients hot fomentation. Basically, we prescribe hot fomentation for the TM joint regions because we need to increase musculature over there. We need to increase vascularity over there. We need to increase the vascular supply over there. And this is what is always done in not just hot fermentations. In our particular department also, we are not just doing hot water fermentations, we are also doing some physiotherapists for the patient. Like we also practice, we also give electrical nerve stimulations. We also give ultrasound therapies. And all these therapists, what they actually do is in turn, they increase the vascularity of the TM joint area as well as the area surrounding the TM joint. So once the vascularity is increased, the pain usually then goes down. So basically, that is how I generally I always advise hot water fermentation to my patients.
Thank you, sir. The next question is by Dr. Shoaib. For how many days can we prescribe muscle relaxants?
Yeah, a very good question, because how long can you give muscle relaxant? But generally, again, I would like to stress that I always give it for 8 to 10 days maximum. I don't go beyond that. Now, if you heard my presentation, along the course of my presentation, I said that I give pyroxicam, and I have got good result with pyroxicam. And there is literature supporting. Of course, I didn't put it up here. There is literature supporting use of pyroxicam. And what are the dosage of pyroxicam? Pyroxicam is usually prescribed in 20 milligram dose, and 20 milligram for maximum 8 to 10 days. You don't go beyond 8 to 10 days. And if there is a need to go beyond 8 to 10 days, that means you're dealing with something else. You're not just dealing with a case of myalgia. It may be arthralgia, or it may be some other condition, but not just a plain simple myalgia. So to get back to the question, not more than 8 to 10 days. That is what I follow. Yeah.
Our next question is by Dr. Mobashir Ali. How to treat clicking sound? If not treated, what will be the results in future?
No. Can you just come again? How to treat, you said, or how to what?
The question is how to treat clicking sound, and if not treated, what will be the future result?
See, first thing now you need to understand, the clicking is just a symptom. Clicking is not a condition. So you are not treating the TM joint sound. You are treating the underlying condition which causes the TM joint sound. So never have this in your mind that I am going to treat clicking, or I am going to treat crepitation, or I am going to treat a snapping sound, or I am going to treat a third sound. These are just different types of sounds produced by the TM joint, which can give you an indication of different underlying conditions or the underlying TM joint disorder. So you never treat a sound, you treat the underlying condition. So based on clicking may also be present in remodeling also. Maybe I could have added this in the earlier question. Like a patient may have, I have seen so many cases wherein the patient has clicking, and after some time it disappears, and the patient is again fine, back to normal. At the same time, I know of a person, my own radiology technician has a very loud click when sometimes we sit together to eat food, and it is heard across the table. And it's a loud click, and he is happy with it. He is not taking any kind of treatment. He is living with it. So why unnecessarily? Generally, I always say that, if the patient is okay with it, you don't unnecessarily do something and induce something in the patient's mind. Unless it's something as grave and as serious like a pre-malignant condition, wherein you need to do something and stop the course or stop the progress of the pre-malignant condition to malignant conditions. So if the patient is okay with it, we don't need to really do anything about it. But yeah, to come back to your question, you don't treat the sounds, you treat the underlying condition. Don't ever have a focus of treating the sound. If you are just identifying the sound and treating it, then you are on the wrong track. You need to identify the condition and treat the condition. And again, like some conditions like osteoarthritis may not be treatable. Many a times you find that they don't have a particular, even if you speak to any orthopedician, they will tell you, or if you have somebody who has a knee osteoarthritis in your family, uh, and you will see that the person doesn't get relieved of pain at all. Patient has just keeps popping pills and several different types of medications, but there is no relief of pain. So some of the TM joint disorders may not be like treatable also, but you need to give symptomatic relief to the patients. So don't treat sounds, to treat the underlying condition.
Thank you, sir. The next question is by Dr. Abhay. For knowing clicking and crepitus, the next question is from Dr. Rohit. Can we diagnose disc dearrangement clinically or MRI is needed?
Again, a very good question. Yeah, can we diagnose it clinically? Because there are limitations. Not everybody can. Not all of our patients can afford MRI. So, clinical examination is important. Clinical examination is must. And in fact, this is another area which needs a broad coverage, is the RDC criteria, the research diagnostic criteria. In fact, recently the research has been dropped, and now it is just a DC criteria. I think it is not so recent also, yeah. But the R has been dropped, and now it is just DC criteria. And they have done studies wherein they have found that if you follow these RDC criteria or the DC criteria, then you don't need an MRI. If you follow the diagnostic DC criteria, you don't need an MRI. So yes, a disc derangement, going by this, yes, can be diagnosed clinically as well. But I'll tell you one small trick that I do, one small tip. May help, may not help. But if at all, most of the times, as I told you, it is anterior disc derangement. So and there is click. Sometimes, of course, there is history of click also, but most of the time there is current click also. I ask my patient to protrude the mandible. You ask the patient to protrude the mandible. When the patient protrudes the mandible, the disc and the condyle relationship becomes normal. Then I ask the patient to open and close in the protruded position. And when the patient opens and closes in the protruded position and the joint sound disappears, means it is an anterior disc displacement case. Now, of course, with reduction or without reduction, it may be a little difficult to identify clinically. But disc derangements based on the DC criteria can be identified. And there are studies comparing only clinical findings and then comparing it with MRI. And they have found good correlation. So that basically tells you that clinically we can diagnose cases of disc derangement. And of course, the second thing is the small tip that I gave you, which I use. I don't know if it's correct, it's validated, not validated, but this is how I identify disc derangements clinically. So maybe you can try and use this and maybe do a study on it and see if it works.
Thank you, sir. The next question is by Dr. Mogit, sir. How long can we give conservative treatment before thinking about other treatment modalities?
Okay. The answer to this, Dr. Mohit, will be the same as that I gave earlier for how long you can prescribe muscle relaxant. Because the duration of, unless you are going to do conservative treatment, means exclusive conservative treatment, like without a muscle relaxant, maybe 4 or 5 days, with muscle relaxant, another 8 to 10 days. So not more than 15 days of conservative treatment. Beyond that, yes, you need to do something else for the patient. Some of the times, I think I remember I had a young patient. She had come with TM joint pain, and in spite of all conservative treatment, the patient kept coming back. And young patient, this was much earlier in my career, so but I still remember that kid, and she used to cry because of TM joint pain. So but I don't remember what we did. But one thing, yeah, coming back to the question, yes, not more than 15 days of conservative treatment. Beyond that, you need to think about something else. Yeah, the point I wanted to make is that you need to also, do some amount of counseling to the patient. You also need to reassure the patient that there's nothing majorly wrong with you. You're absolutely normal, and if there is something wrong, we will take care of it. Because what happens, some patients may have some psychological aspects to this pain, and then it, it- a good communication with the patient, a good rapport with the patient, then helps the patient to come out of that pain. But yeah, coming back to the question, not more than 15 days of conservative treatment.
Thank you, sir. The next question is by Dr. Arvind, sir. What are your views and experience on cognitive behavior therapy for TMJ disorders and your experience with tricyclic antidepressants?
Yeah, I'll take the second half first. My experience with tricyclic antidepressant. This patient, I'll just put up that picture also for you here. No, not this one. This particular case that I showed you of this bifid condyle, this one. The patient had good amount of relief with antidepressants, by the way. So yes, there is a role for antidepressants and cognitive therapy in TM joint disorders. Of course, it has not been studied in a big way, so we really don't know. But my experience says that yes, there is scope. There is scope.
Thank you, sir. The next question is by Dr. Sayani. Treatment for bifid condyle.
Treatment for bifid condyle, yeah. You know what? Long time back, generally I usually attend this international DMFR conferences quite regularly. And at that point, I think maybe around 10 years back, before, or at that time, the editor of DMFR was Dr. Sharon Brooks. And she had, in fact, she had come to India and she had done a presentation. And at the end of it, she comes down and tells me, don't ask your colleagues to send bifid condyles for publications. They are just anatomical aberrations and they don't need any active treatment. So, frankly speaking, yes, bifid condyles you may find in many cases. Sometimes you may find it as like a clinical, in a clinically absolutely normal patient. So you don't need to treat bifid condyles. But yes, in this particular case, this bifid was like huge. And there was a deep groove here right in the center. And I was just wondering if there was entrapment of the disc. Of course, this is just a thought. So the point I want to make is that bifid condyles don't need any treatment.
Thank you, sir. The next question is by Dr. Rohit. After condylectomy, is there any new procedure for remodeling of condyle so that it works normally?
I am not very sure if I have understood the question properly, but if you are trying to ask that if condylectomy is done, and is there any scope for regeneration of the condyle? If
Yes,
that
sir.
is a question,
Yes.
yeah, then I don't think so. There is any scope for regeneration of the condyle. In fact, the surgeons generally place some graft material over the condyle area. So if there was a scope for condyle to be regenerated, why would a graft be placed in the condyle area? Isn't it? So there is no scope for regeneration of the condyle. Definitely no. I have not come across any such article. If somebody knows about it, please forward it to me. Even I would like to see if there is a scope for regeneration. I mean, I have never come across it. And I think, yeah, if it is done, it's great.
Thank you, sir. The next question is role of exercise in management of TMJ disorders.
role of exercise in management of TM joint disorders. To be very frank, I don't have much idea about this, but basically, see, like any other joint, if there is a joint disorder, you generally, any other stress-bearing joint, apart from the TM joint, you generally give rest to the joint. Isn't it? If a patient has a knee joint pain, you don't ask the patient to do knee exercises. Isn't it? You don't ask the patient to go and run. You ask the patient to give rest to the knee joint. The same way, if the patient is having active pain in the TM joint, if you see all our therapists are stressing on giving rest to the joint. Don't open too wide. Don't eat too hard, too much of hard things, such that it will lead to stress on the joint. So the basic goal of treating a TM joint disorder is to give rest to the condyle and not to overstress it. Okay. So yeah, I think exercises, as far as I know, again, I am open to discussion about this. I don't think so there is much scope about it.
Thank you, sir. The next question by Dr. Gayatri is best treatment modality in PMJ cases.
Yeah, yeah. I mean, I would say that there is nothing called as best treatment. The treatment which helps your patient is the best treatment. In some patients, just recounseling the patient that nothing is wrong and reassuring the patient helps. In some patients, only conservative treatment helps. In some patients, there may be a need for some other treatment, like maybe some joint injections may be needed. In some patients, there may be need for surgery. So there is nothing called as best treatment for a TM joint disorder. It depends on the TM joint disorder. It depends on multiple other factors like the age of the patient, the severity of the pain, what condition you are dealing with. So there is nothing called as one treatment suits all. I mean, TM joint disorders can't be treated like you have, say, carbamazepine is the drug of choice for trigeminal neuralgia. We don't have this particular treatment is the treatment of choice for TM joint disorder. No. For different disorders, there are different treatments. There are multiple treatments. There are multiple work going on different treatments. So things will keep evolving. You never stick to one particular treatment. Things will keep evolving. Maybe 10 years down the line, things will be still different.
Thank you, sir. The next question by Dr. Karpagavali ma'am is role of PBM or low-level laser therapy in treatment of TMJ disorders.
Yeah. Even I have read about this, the low-level laser therapy. And basically, it is again the same thing as it helps in cases of myalgias. Muscular pain, yes, low level laser therapy has been found to give good results in patients with myalgia. And of course, I have read this in the literature. We have never done it. In fact, one of my PG students is currently doing a short study on it, and we have got good results. I was just reading through her results, looking at her results, and yeah, we low level laser therapy definitely has a role to play in myalgia cases.
Thank you, sir. The last question for the session is which book to refer for MRI of TMJ?
Very good question. Again, I would say a good question. Not that the other questions were bad. Please don't say come to that kind of a conclusion, because to me every question is a question and it should be tried and addressed to. So yeah, I mean, I would say a good question to finish with. Which book to refer? And generally, I refer Okeson. Okeson to me is a fantastic book. For it has only a small chapter on TM joint, but to me it is a fantastic book on both MRI as well as CBCT for TM joint disorders. Apart from that, I don't remember one book. We have one book in the library, but I don't remember the name, which is also good. But I love Okeson. It's a good book.
Thank you so much, sir, for this wonderful session. We have received an incredible response with more than 300 participants over Google Meet, Facebook, and YouTube. Now, I hand over the session to Dr. Abhishek Sadi, sir, for vote of thanks.
A very wonderful speech, sir. And it was a very informative session, and I'm glad to be here. So, I'm Dr. Abhishek, and on behalf of the organizing team, I express my heartfelt gratitude to the Almighty Lord Jagannath to keep us healthy and make us good things happen in these tougher times. So, I thank our esteemed founder president of Shiksha Anusandhan University, Professor Manoj Ranjan Nayak, for his continued patronage of all our academic activities. I also thank Professor Ashok Kumar Mahapatra, Honorable Vice Chancellor of our university, for the never-ending support. I am indeed indebted to our dynamic dean, Professor Neeta Mohanty, who had conceptualized mega webinar series. And it's a great pleasure. I thank to Dr. Kaustubh Sansare, sir, for being part of our webinar series and enlightening us on this enigmatic topic. And I am obliged to Dr. Shalura Madam, Honorary General Secretary, for her support, and gratefully acknowledge the team at Tropin for their cooperation. I also thank Dr. Satyaranjan Mishra for planning this mega webinar series, getting the experts to talk on the topics of clinical importance and implement it very smoothly. No event can happen without the teamwork which divides the task and multiplies the success. I thank my colleagues, Sir Dr. Sanat Punya, sir, Dr. Rajat Panikrai, Dr. Smita Priyadarshini, Dr. Basant Chaudhary, along with the efforts of our hard-working PG students, Dr. Rupsa, Dr. Shushmita, Dr. Suvarnita, Dr. Namrata, Dr. Purvasa, and Dr. Ananta, who made this possible. And last but not the least, I thank all our participants who have patiently carried out this entire webinar series in spite of the technical glitches which were there. And most of it, this academic session was a wonderful experience for all of us. Now we will wind up with today's session. Thank you all.
Well, I would like to say thank you to all of you, to the entire organizing team for having me here and having considered me as an expert to be a part of this kind of expert webinar series. And I'm great that I'm being considered with, I'm really thankful that I'm being considered with some other speakers like Dr. Umarji and Dr. Arvind and Dr. Kritika. I am really indebted to that. And thank you, Satyanaranjan, Dr. Mishra, for having me here and bearing with me.
So thank you so much, sir.
Thank you, sir.
So it was really enlightening. And Omarji sir was there and he has praised the pictures and everything.
Wow.
He was listening to it, sir. Thank you again, sir.
Yeah.
Till next time.
Yeah,
take
sure.
your leave, sir.
Yeah. Thank you. Bye-bye.
Bye, sir.